Hi, my name is Dr. Ken Mathis, and I'm an associate professor of orthopedics at the University of Texas Health Science Center in Houston, the McGovern Medical School. And I'm going to talk today about joint replacement. And the title of my talk is Where We Are and Where We Are Going. First, I want to tell you about Texas Medical Center. It's the world's largest medical center. There's over 160,000 employees, 54 institutions, more than 7 million patient visits a year, 3 medical schools, and all the institutions in the Texas Medical Center are not-for-profit. So I have some questions for everybody to think about. When do you think the first artificial knee was placed using a cement? Second, is it cheaper to do a hip replacement than to not do one for society? Third, how long will a hip replacement last? What do you think? 10 to 12 years? 15 to 20 years? 30 years? And can people run marathons with a current total hip replacement and it be okay? So if you don't know the answers to these questions, stay tuned, and I'm going to give you the answers to every one of these, and some of them may surprise you. So I want to talk about just the burden of musculoskeletal disease. It's significant. It's the leading medical condition in the U.S. It is twice as prevalent as circulatory and respiratory disorders, 5 times more prevalent than diabetes. Chronic joint and back pain are the #1 reason patients visit their doctor, and it's the leading cause of disability in this country. 63 million adult Americans suffer from chronic joint pain, and over 21 million of them have arthritis-related activity limitations. And currently about 2 million Americans receive a knee or hip replacement a year. If you look at the dramatic change on this graph, you're going to see on the left that the population age 65 and older is going to double between 1995 and 2030, as will the number of people with doctor-diagnosed osteoarthritis. And you look on the right, it shows an explosive growth projected in total joint replacement, over 674% increase for total knee arthroplasty is projected between 2010 and 2030. So we're not training 674% more total joint surgeons, and those doctors that are doing it are going to be getting busier. It's one of the most successful therapies we have in medicine. Studies demonstrate rapid and substantial improvement in pain, functional status, and overall health in 90% of patients after a total joint replacement. And studies that will show a nearly 100% return to work rate after you get a joint replacement. And the biggest decline in disability today comes from musculoskeletal disorders, accounting for 25% of the total decline, in part attributed to total joint replacement. It's also one of the most cost-effective. If you look on the left, there's a graph that shows cost versus quality of life years. And that's a threshold that countries use. In Europe, it's about a little less than $60,000. And you can see the THA, TKA, TSA, that's total hip arthroplasty, total knee arthroplasty, and total shoulder arthroplasty, compared to the quality adjusted life years for a coronary stent and hemodialysis. And you see the expense yearly in hemodialysis, which is why in some countries in Europe, if you are over 63, the government-run healthcare will not pay for your dialysis. And if you can't pay for it yourself, it's not offered. But if you look at the cost to get a total hip and knee, it is very cost-effective. And if you look at the lifetime costs on the right, you see that for a total hip and a total knee, it's actually cheaper for society to do those surgeries and pay for them than to not do them. And the reason is people that get these joint replacements are able to continue working, able to continue living alone. They don't have to go into a public-funded nursing home because they're crippled. They're able to stay in the workforce. They're able to live independently longer by getting these arthritic joints replaced. Well, when we started artificial hip and knee replacement surgery, what were our initial goals? Number one, it was to relieve pain and improve function. And our goals were modest. We were looking at low demand activities with modest goals, And we wanted the device to last as long as we could. Well, I'm about to show you how those goals are changing. And the goals now are allowing highly motivated individuals to do what they desire. The very first artificial knee replacement that I could find in the literature was put in by Themistokles Gluck. And he was German in 1890, designed and implanted an ivory hinge knee replacement. He did it in 5 patients, used a type of bone cement that he created, and all 5 of these failed. Number 1, the material was ivory, and it wasn't very durable. And number 2, all 5 of these got infected, and he was expelled from the German Orthopedic Society. This is a drawing in a journal of that knee, and you can see that the published journal was 1891, with a very forward-thinking philosophy that an ailment or a human condition could be improved with a mechanical device. And we were trying to do this in the 1890s without success. We began to see some success in the 1950s, 60s, and early 70s. And these early knee replacements were literally hinges. And I've got pictures of these devices. They were typically implanted without any bone cement, and they became loose because they were very constrained. The knee itself in humans is not a hinge. And when the knee tried to do the normal movements it does, it would work these devices loose, and they failed very early. But we were still trying to make improvements. The materials were clearly better. It's not ivory. I've got pictures now on the screen showing you some of the things we're doing now that are even partial knee replacements. In other words, if you have arthritis just in one part of your knee, you don't need to have a covering over the entire joint. We're able to put in these devices that you can see are analogous to getting a cap, like a cap on your tooth, or resurfacing a tire with gluing a new tread on it. Our devices are profoundly different than the hinges that you see, and allow us to keep patients' own ligaments and tendons and not remove or cut any of them. So the person who's considered the father of modern joint replacement is a gentleman named Sir John Charnley. He was knighted in Europe. And in 1958, he made a huge breakthrough with picking some materials that actually work and we still use today. Despite looking for better materials, he came up with the idea initially of Teflon as a bearing surface, which wasn't a good idea, but he subsequently came up with something called ultra-high molecular weight polyethylene, and he popularized the use of PMMA, which is polymethyl methacrylate, and that's the bone cement that we use now. And despite decades and a lot of researchers looking for something better, we are still using the same material. We've just figured out ways to make it stronger and more durable. So an example is we've improved the polyethylene. Now, when Dr. Charnley was implanting hips and when I was a young doctor 30 years ago, we might tell somebody that your artificial joint may only last 10 or 12 years, and it'll depend upon how active you are and activities that you do. But we've made dramatic strides. We have actually lowered the wear rate of this polyethylene, the plastic that we're putting in the joints, by 96%. If you look at the graph on the left, it shows conventional polyethylene, and with the highly cross-linked or improved polyethylene, you can see the dramatic decrease in wear. Even though we've changed how we manufacture the polyethylene to make it much more durable, that the new improved polyethylene in the light blue is actually even stronger in some material properties than the conventional polyethylene that we had. So it's not just lasting longer, it's even more durable. One company has even received an FDA clearance for a 30-year knee, that they've put this device in a wear simulator, simulated 30 years, and the FDA will let them market it. What I'm showing you here are some different articulations, and where the big green arrow is what the primary one used in the United States, a ceramic, that's the CE, and XPE is cross-linked polyethylene. If you look at standard polyethylene on the far left of the graph, you can see this dramatic decrease in wear. And these are simulations of the tiny particles with the walking that are generated in a total hip replacement. So what's the future? We're going to see improvements in devices continuing, and we can see them in the pipeline now. We're looking at infection-resistant coatings. So one of the problems with any surgery is you worry about infection, and having an artificial joint in provides a place that germs can hide in the cracks and crevices of the metal and plastic, and your immune system and white blood cells have trouble getting in there, as well as antibiotics have trouble getting into the small cracks and crevices. Well, if we can make the coating or make the device resistant to bacteria sticking on it, then we've reached another level of plateau and solved another problem. We're looking at improved function, and the devices that I put in 30 years ago are not nearly as good, don't have nearly the range of motion and function that the devices we have today. And I'm going to show you a device that actually allows high-demand activities such as running, including marathons. And I have patients with a certain type of device competing in these high-demand basketball, running, snow skiing, etc. We're looking at improved ways of putting the devices in, and there's a lot of early work now being done with robots to help us implant the devices, and we're hoping that that improved precision will lead to improved results. We're looking at navigation without a robot, but a way to use like a GPS to better line up implants. Another dramatic change is outpatient joint replacement. We've made huge strides in pain control and preemptive analgesia, meaning blocking pain before the patient feels it, so that patients get up after surgery, will be walking in the hall the same day, and feel like they're able to go home. And so the majority of our patients go home the same day, whereas it used to be a week or 10 days in the hospital when I was a young physician. We're also personalizing treatment. Not everyone gets the same device or the same types of implants, and we look at things they want to do and unique aspects of the rest of their body and the other joints that we can create a plan for them that's unique. So we talked about new coatings are coming, and here's an article, a review article looking at different surface treatment strategies to combat implant-related infection from the very beginning. Here's an article by Dr. Barrick, The Case for Hip Resurfacing, a Bigger Picture. And this article shows on the bottom left x-rays of conventional hip replacements, and in the middle you see these hip resurfacing devices. And what's unique is that they are not a metal or ceramic on that polyethylene, but they're a metal-on-metal device. And there have been some poorly designed metal-metal devices that have been taken off the market because they didn't perform well. But this device has been sold worldwide since 1994 and in the US since 2006. And what's remarkable is that these patients are able to do high demand activities. And I put a red circle on the bottom of the graph. If you look at the percentage of folks with a surface replacing arthroplasty or a hip resurfacing, SRA, that run for exercise, the percentage of folks with this device, 47% are using running as a form of exercise after this device. So to answer one of those questions at the start of the talk, yes, there are devices where you can run and run long distances. The next frontier that we're looking at is robots. Now, why would we want to use a robot to put in an artificial joint? If you look at the world in general, whenever there's a new change in technology, there are people that say, I don't think this is really a good idea. If you look at this quote, I think there's a world market for maybe 5 computers. That was the chairman of IBM on seeing the first mainframe computer in 1943. Steve Ballmer in USA Today quoted, there's no chance that the iPhone is going to get any significant market share. That was 2007, how wrong we were. So right now, robots are still, in my opinion, experimental. We have 2 at the hospital where I work now. We're looking to get a different third one to look at. And we think in research centers that if we can use them in the laboratory and validate and improve their speed and their precision and their accuracy and prove that this is a good thing, we're going to see them roll out more widely. If you look at the Industrial Revolution, on the left, a big advance was the assembly line that Henry Ford created. And you see all these men and people on the assembly line, but if you look here at a Tesla factory in 2017, you can't find a single person in there working. I'm not suggesting that we won't have surgeons in the operating room with the robot, but what I am saying is that robots are becoming a bigger and bigger part of our society, and including medicine. So what are some critical factors for success in joint replacement? Number one, if we look at an artificial hip, you've got to prepare the bone, and this is an x-ray of a typical artificial hip. And you've got to pick the right sizes for the patient to get their legs the same length or as close as you can, and the offset or how the biomechanics of the joint work. And so preoperative planning is essential. You've got to position the implant in the optimum position, and it's not quite so simplistic. There are rotational aspects and angular aspects of that implant fitting in the bone. It needs to fit very tightly in the bone, and the soft tissues need to be balanced. And all of these things take a lot of time and training to get correct. So what robots are in medicine? And I've got some examples of different robots on this slide showing you that there's not just one. There are many that are currently in use and more are coming. So what does the data show with early studies? It shows that we're able to get the implants in slightly better position. There may be some element of soft tissue protection, and we need more data and longer studies to show, and our hope is, will this decrease failures and will we get slightly better functional outcomes? But we have not definitively proved that yet, that a robot can do it better than a good surgeon. I've got an example here on this slide of a surgical workflow, and I'm just showing this to show you that this is not what conventional surgery used to look like. There was nothing like this. These are actually images that you see in an operating room on a computer screen while the surgery is ongoing. We're going to see personalized orthopedics, and we talked about that earlier. Preoperative planning, how important it is that we will, in the future, I think, be developing custom implants put in a unique way just for this patient to fit their unique anatomy. So we're also experimenting, and you can see on the bottom right, these are currently in use. These are 3D printed guides that a CT scan or MRI is made preoperatively. The devices are conventional devices, but these guides will allow pins to be placed intraoperatively that optimize the alignment of the device. So in other words, the surgery alignment and positioning of the implant is done a week or two ahead of time, or as long as a month or more ahead of the actual surgery on a computer screen. And these devices allow pins to be placed that allow those cuts on the bone that the caps fit on to be placed in a very accurate position. So we have fluoroscopy, which is a real-time x-ray with templates that can also help put in implants. Navigation, haptic robotics, which is a robot that you don't push a button and stand back and the robot works. In other words, the surgeon still has to use the cutting tools to do the surgery, but if he or she is about to head in the wrong direction or not put it in an accurate position, the robot won't let the instrument move. So it's on a robotic arm, the burr or the cutting jig, and the robot won't let you make that choice. On the other hand, the surgeon may look and go, hey, we can't make a cut in that area, that's not safe. And even if the robot thinks it's okay, the surgeon has a safety factor to go, no, I don't care what the robot thinks, we're not going to do that. And we mentioned custom implants. So there's a lot of very exciting technology for the future as we're moving forward. So what are we doing at UT Orthopaedics? As I mentioned, we've got robot sites all over the city. We have the Center for Orthopedic Research and Innovation in Technology lab here at the Memorial Hermann Orthopedic and Spine Hospital. We're doing resident and fellow education, training the future orthopedic surgeons that will be all over the country. We're doing research into new robotic applications, not just to put in artificial knees and hips, but are there other orthopedic procedures that we can make more accurate with these devices? And we're doing research on changing the surgical glove, gown, and spacesuit designs to reduce infections. Well, I want to thank you for your time and viewing this video. And if UT Orthopedics can help you in any way, please come see us.